We are here today with Jake Lancaster, Chief Medical Information Officer at Baptist Memorial Healthcare, CMO at Baptist Medical Group, and co-host of the Right Care at Baptist podcast and the Baptist Management System Connecting the Dots podcast. Jake, thank you so much for joining us here today.
Glad to be here. Thanks for having me.
Sure. So today what we're going to do is we're going to dive into a pilot project that you've been working on over at Baptist Memorial Healthcare, and that's with the Dragon Ambient Experience, or DAX, pilot. For our listeners, DAX is a comprehensive AI-powered voice-enabled solution that uses ambient sensing tech to listen securely to patient clinician encounters. There's a phone app. It's part scribe, part AI. You started this demo this past summer. In addition to talking about what it is and how you're using it, I know there's other episodes out there where you've described that. I think our listeners are particularly interested in the challenges of implementing this new technology. So I'd like to ask you, in addition to speaking about the nuances of how it's unique to Baptist, Jake, would you tell us about what some of the cultural challenges are associated with the implementation?
Yeah, it's a great question. So yeah, you described the product, very well. The goal of the product was to have a virtual scribe for the physicians, so they're not spending as much time documenting in the note. Burnout's high. We're really trying to get them more time with patients, more time at home, and so using this virtual scribe software as a way to reduce that burden, it was the goal. What were the challenges? Well, there's quite a few, starting with, we initially were looking for 15 physicians, 15 providers that were interested in going live with the software. Using our internal data, we were able to identify those that were that could benefit the most from it. So those that were spending a lot of time in the chart, those were spending a lot of time after hours and notes, were the ones we really focused on. And so we approached them early on about, hey, would you like to participate in this pilot? Now, when you start saying artificial intelligence, you start saying, apps to some of these physicians that are struggling with the EHR, you get a lot of skepticism. I mean, they don't want to try and pilot a new tool, in that manner. There may not be the best people to pilot the software. But if you went to your doctors that are maybe part of your informatics group and come to all those meetings, they're already really efficient in the EHR, and so the benefit, the ROI of the software might not be there for them. So it was really tough to find that sweet spot of the physician who would embrace and be willing to try something new, with those that are also struggling. So I would say of the 15 initial providers that we approached, we probably got half that were in that, struggling group, that, really saw the benefit. And then we actually had half from our informatics, interest group that helped us out because we couldn't find any more to fill those licenses. So that was struggle number one. And as we saw, that played out actually at the end of the pilot, the ones that struggled the most, that we identified as benefiting the most, were the ones that ended up wanting to move forward with it going forward. And then that the ones that were efficient already, some of them decided that it wasn't necessary for them. So it but it did help spread the word to the rest of the physicians that it was useful, and it's not as scary the second time around.
So Jake, I want to go out on a limb. Maybe some of the patients who are some of the providers are spending a lot of time after hours. I wonder if there's a correlation with perhaps an older provider population and the more efficient ones are younger. And the reason I'm going there is because I want to talk about bedside manner. It may not be the first thought that comes to mind when you're thinking, oh, well, if I'm reducing time putting in notes during a patient interaction, you actually have more time with bedside manner. I've heard it said that there's been less emphasis for younger graduates in the last decade or two of medical school to teach them about bedside manner. So I'm trying to see what kind of positive and negative externalities may there be with this program. What I'm trying to ask basically is, if you free up more time for a patient-provider interaction, how does that affect the interaction? How does that affect the patient experience, the provider experience? Is there anyone who has trouble with having more time with patients?
That's a good question. And so looking at, I guess, the demographics of the physicians that went live on the software, we had a mix of old and young. We had a mix of male and female. If I haven't looked at a cross section of our data, but there's other studies out there that have done that with who spends more time with patients, who spends more time with in the EHR and writes longer notes. And it tends to be your female population will spend more time with patients and write longer notes. And we certainly see that with some of the ones in our pilot. The physician that was spending more time than anybody else in the system writing notes was female. And she had been in practice for a while, but we certainly also have younger females that will spend a lot more time in the EHR. And what do they do with their time when we give them that time back after they've been using the software is a good question. And we do have some survey results. 83%, I think, said that they were able to spend more time with patients and had, higher patient satisfaction due to their perception of using the software. We got a lot of anecdotal comments that they were able to get home in time for dinner. One said that she was able to exercise and hadn't been able to do that consistently for a while because of the work after hours. So, some are choosing to spend more time, outside of the office, which is what we would hope for. I would imagine that, some are also spending, a couple of extra minutes, maybe with patients or face-to-face visits. But I think it really comes down to they're not having to, and this came from one of our physicians, and he mentioned it on the podcast we did with him recently. In the room, the app is recording your conversation, so you don't have to worry about making a note in the chart while you're seeing that patient. A lot of them will have the EHR still up so they can place orders or review lab data with their patients that way, but they're not having to spend any time pre-charting in their notes. So they're getting about 3 minutes back per appointment using the software, about 30 minutes a day. And so some of that will go into more direct patient care or more face-to-face time with the patients, I imagine. And then some of it hopefully is being spent doing outside healthcare work or not work, but enjoyment with family, friends, whatever they want to do.
I've heard you speak about some of the goals of this program being to alleviate burnout, reduce burden, documentation burden, increase efficiency, improve throughput, and integrate into the new workflow. One of the providers you interviewed said that on average, he had been spending 3 hours a day documenting his notes after he finished seeing patients, and that's now reduced to 30 minutes a day. I guess the question I'd like to ask is, how have workflows been affected? How have patient outcomes been affected? How do you think this may affect turnover? And of course, if it's too early to say, then how do you expect it may affect those KPIs in the future?
Yeah, so a couple different questions there. The workflow question is an interesting one. The doctor that you just mentioned said he did have to adjust his workflow to the software initially. And I think that may be one of the challenges that I didn't talk about at the beginning when you asked the question was, it's not just an app you download on your phone and you go about your business the same way you normally would. You really do have, in order to get the full benefit, you kind of have to adjust your templates, adjust the way you interact with the patient slightly. And for some, that's easier to do than others. But if you really want to get the benefit out of it, the full benefit of it, you really need to embrace and do that piece. For that particular physician that you mentioned, he said that he early on only was using it for certain visit types like acute visits, but then really got the benefit more when he started using it for more chronic disease management later on. And so that allowed him to get those extra hours back per day. As far as things that we are really looking for, you mentioned the big ones. My goal as the CMO, as the CMIO, is really to drive down that burnout, drive down turnover. We've had some say essentially that they would have retired this year if it was not for this program. And if we took it away from them, they definitely would retire. So it's we're we don't know the impact on total turnover right now. But we're hoping that it will allow, especially some of those at the end of their career, to stay a little longer and not be overwhelmed, and then just extend the careers of some of the others that may decide that medicine is, especially primary care, is too much for them, and they would pursue something else. So they would stick with primary care longer.
A few follow-up questions. One, when we say provider, are we only talking about a medical doctor, or are we also referring to nurses for whom there is a high turnover rate across the United States?
So when I say provider, I mean the traditional way to describe it. It's a physician, nurse practitioner, or physician assistant. Midwives also fall into that category. So any of them would be eligible for use of this. We've not trialed it with nursing. We have some other initiatives they're working on with nursing. It is not a free tool, so it certainly is. It's something that we're actually asking our physicians to help cover the cost for, through either seeing more patients or just sharing that cost with us directly. So that would be a little bit tougher to do on a nurse's salary, I would think.
So the provider that we referenced earlier, who's saving 2.5 hours a day, he mentioned he was skeptical early on. Many of our listeners are similar to you, CMIOs, CIOs at large healthcare delivery systems across the country. When they encounter a skeptical provider, they often, when they get pushback, it's difficult to get them to come on, even when you can use data to demonstrate the value they may receive. How did you convince him to join the program when his initial reaction was he just didn't want to be part of it?
Yeah, it's a good question. And, I had better luck with him because he is he's actually the CMO for our clinics down in Jackson, Mississippi. And he's on my physician informatics group that we meet. And so when I was looking for extra people to be part of the pilot, I really turned to that group and got them to join. Didn't make them, but kind of asked them several times, and maybe it was a little annoying before they joined. And so, yeah, he was skeptical when he came on. He didn't think he needed it. He was, again, very, very efficient doctor. But he was a high volume doctor, sees 30 plus patients a day. And even though he was efficient, even saving a few minutes per encounter saved him a ton of time, like he said, in the order of magnitude of hours for him. And so once he trialed it, he started talking to his colleagues down in Jackson. And now I get more requests from them about, when you're going to open this up to the rest of the population than any other place in the system. So it's that word of mouth from somebody that is using it that has really helped them. I think the testimonials are key. So the pilot at each organization is pretty crucial to making it last or making it go forward. If we wouldn't have had half the doctors in the pilot say that they will go forward, not only do they want to move forward with it, but they're willing to pay for it out of their own pocket because it's changed their careers, it would have been tough to find others to do so. Now I'm hoping that with some of these testimonials, I can share those with those that we approached at first, that were skeptical of new technology, the ones that are really struggling, and convince them that it'll really give it a try, and that it's going to help them.
What are some of the challenges of expanding beyond the pilot to the rest of your provider population?
Yeah, so one of the big challenges for us is the model we have set up is we're asking the providers to cover the cost of it so that we can expand. It's been a tough year for health systems if you read the papers. So we don't have a lot of free cash lying around, even if it's going to reduce turnover, if it's going to make you more, Dax will share that there's an ROI to this. It's hard to convince your CFO to fund something like this. So making it cost neutral was something we wanted to do. And so by doing so, we have to ask the providers to either see more patients or share that direct cost. With the pilot, we had some from our foundation, some money from our foundation to sponsor 3 months of licenses for these 15 physicians. We don't have that money anymore. So going forward, if a new person wants to trial it, they'll have to pay for it. at least for that first month. If they don't like it after that first month, then we can repurpose that to somebody else. But that's a challenge. It's it's a bit of a risk for that provider especially if they get off to a rocky start, which can happen. Their model, the way it works, is early on. There's not as much artificial intelligence baked into the scribe process. It's mostly a third-party group that's overseas that is actually serving as virtual scribes that are doing this. Then after, I forget how many encounters, the AI kicks in more. But early on, you're relying on people to transcribe these and dictate these for the providers. And the quality will vary between those scribes. And so if maybe, one provider in that first 30 days that they're trialing it gets some variation that they're not happy with, they may not continue with it.
Mm-hmm.
So overcoming some of that will be a challenge for us to move past the pilot phase.
Are your key KPIs reducing turnover and improving patient satisfaction with HEDIS measures, or are there some other KPIs that you're using to evaluate the success of the program?
Yeah, so right now I'm mainly looking at our data in Epic Signal, which is time and notes, time spent after hours, and pajama time is the majority of what I care about. And then I want to make sure that those are going down, that they're spending less time in Epic. That's the only, and if they're satisfied with the product, it doesn't matter to me because it's cost neutral for us as a system.
Right.
That I mainly want the physicians to be more satisfied and have less burnout. All the rest, patient satisfaction, everything else. Yes, if that improves, that's great. If it goes down, yes, we'll have to reevaluate. But I couldn't imagine that happening. But the main thing I'm worried about is just reducing that burnout and stress.
What would it take to get an executive sponsor with actual funding behind it at Baptist?
Well, first of all, I think just the ecosystem that we're living in, the financial environment that healthcare is in needs to turn around before a system like ours, who doesn't have some large, foundation, endowment, innovation fund available, that environment needs to turn around a little bit before we can, support something like this at an enterprise level. Certainly, and I'll help with analyzing that data. If I'm tracking these providers over the next year or two, and we are showing huge ROI, huge number of being able to add spots, and I'm able to take that and show it to the CFO that, it's actually cost effective for us to pay for this, for the providers instead of asking them to share the costs, then that may be a different conversation that we can have. But we'll need a lot more data and a little bit more time, and probably a better financial environment for large healthcare systems. And
so, Jacob, I've heard you previously mention that one of your top goals is, in addition to reducing the documentation burden, you're also, as an organization, looking to increase patient portal signups and patient engagement in your patient portal, your digital front door. Have you found any correlation between the use of this product, which leads to more patient-provider interaction time, and actually achieving that organizational goal of more patient engagement?
No, we've not compared it to patient engagement. I would say that most organizations have had that patient engagement, patient portal sign up as a goal prior to the pandemic. With the pandemic, if you had that as one of your organization metrics that you were tracking, you hit that easily in 2020, 21, and 22. It was everybody flocked to online options. And so, yes, that is still something that we have out there as a goal, but we essentially achieved what and surpassed what we thought was an appropriate goal at the time, just because of the way the world turned. Yeah. So that has created a different problem, because now that we have so many patients on MyChart, on the patient portal, sending messages to their physicians and pools digitally, you may have seen that in-basket messages, patient messages to physicians have spiked over the last couple of years. And that has put a different burden on our primary care doctors that I'm working on also, which would probably be a different episode.
Yeah. So I think there's kind of a suite of questions that are all related I want to ask you to delve into, and I'll let you determine how you'd like to answer. I'd like to ask about the quality assurance challenges on the back end. You said there's variability in quality, but also because you're using a third-party app and people who are transcribing, it presents potentially a new cybersecurity risk. And I'd like to ask how you, and then you also have a cloud migration strategy. Is this on-prem? Is it in the cloud? So a variety of implementation challenges. So just to review, I asked about QA with variability, cybersecurity, and cloud migration.
Yeah, so the QA comes in a couple of different ways. Like I said, DAX and Nuance have been, very supportive. If we do have concerns about particular quality from a particular scribe, their scribe name is listed, on the note, and so we can communicate with them and let them know, hey, this person is not doing a good job. And what they can do is they can reassign only certain scribes to that particular provider.
Mm-hmm.
So, we've had to do that in a couple of cases where provider said, I've been working with these worked really well, these not so much. I'm having to go in and actually, change spelling errors, grammar errors, things of that nature. And they've reassigned to have a little bit more tighter focus on with a smaller number of scribes for them. Also, and like I said, the AI piece is not fully kicked in yet, but each time the provider gets the note back, they edit the note, and then those edits are sent back to DAX so that the engine can learn what was changed from what they had sent over, with the hope that, and my understanding is that in the future, those changes would be baked into the artificial intelligence. We're too early in the process to know if that QA piece is working yet, but that is part of what is built in. And they have been very receptive if we do have, thoughts or suggestions about ways to change, at least in my experience early on. We'll see what it's like post-pilot. Cybersecurity challenges, like any new technology we bring on, we do have our security review it, and to make sure that it meets all of our standards for, encryption with the data in transit or in rest. I don't say as far away from that process as I can, but I was not part of the security review. I just know it passed our security review, and we're a fairly conservative organization. So if there was a big cybersecurity risk, I would have expected our team to pump the brakes on it.
Mm-hmm. And any implications with the cloud migration?
No, not for what we're doing. We're participating in Epic's hyperdrive migration, to its more web-based platform, and then also Nuance is using this in the cloud. So that it really wasn't anything specific. The main thing that we have to do is send HL7 messages over to DAX so that they know what the physician's schedule is for that day, so they can get match up the recording to that patient and then put it back into Epic.
Got it. So we are approaching the end of this podcast episode. Given that, I'd like to invite you to offer a message to our audience to wrap things up. Maybe they're looking to implement a new innovative program to address some of their challenges or physician turnover, burnout, to improve patient experience, patient engagement. What have you learned from this process that you might be able to share with other tech executive leaders, peer organizations that you think could be helpful if they were to try to implement a pilot project similar to this?
Yeah, learned several things. First I would say that it's one of the more successful pilots I've had. As far as feedback from the pilot group, we put out a lot of new features, a lot of different things, and I asked my informatics group to help pilot. And a lot of times I get back, a few, oh yeah, it's helpful, but it's not going to make a large impact on my well-being. This is probably the most significant thing that we've put in to help with physician well-being that I've ever had. And I would say that would encourage me to continue. Early on, I got nervous because I saw a presentation on this at Epic UGM or XGM, and it was a rocky start for one group's pilot. They mentioned that it really took 100 days for the physicians to get used to the changes and get comfortable with the software. And we only had a 90-day pilot, so it's like, well, we're going to be 10 days short. But I was really encouraged when I heard back from some of the physicians about how great they liked it even within the first couple of weeks. The second thing is choosing your pilot group is very important. Ideally, you're going to want somebody that is in clinic every day, seeing a fairly high volume of patients, and also, spending a significant amount of time in notes. It's not going to be for the person that is, part academic, part in clinic, or somebody with a more administrative role that's in clinic a couple of days a week. It really needs to be somebody that's probably there, full time to get that full benefit. And that being said, it's going to be tricky, at least early on, to again find the ones that are in need the most, but also willing to adopt something new. And so that's you'll just have to work within your organization, know who your docs are that are easier to work with than others, and circle back to the ones that may be more late adopters after you've ironed out a few of the kinks.
Well, thank you, Jake. Again, for our listeners, this has been Jake Lancaster, Chief Medical Information Officer at Baptist Memorial Healthcare, CMO at Baptist Medical Group, and co-host of 2 podcasts, The Right Care at Baptist and Baptist Management System Connecting the Dots podcast. Jake, I'd like to thank you for joining us today.
Thank you so much, Jordan.